Thanks, Eric. I always feel like a student whenever you're giving your talks. It's unbelievable. We have about 5 minutes left before we go to break, so maybe we can go down the panel and ask people what's your algorithm at this point for medical management, post-endo, post-bypass, et cetera. You want to start, maybe, Brian, if you don't mind?
So I'm starting to follow these guidelines more and more. But I will say, we only have so much time with our patients in clinic. We don't follow them as longitudinally as we'd like at times. And one of my challenges is getting over that mental barrier of putting patients on high-dose statins, for example, and monitoring them for side effects. That has the potential of upsetting the primary care docs and their internists. And so
cost, it's expensive.
I'm starting to do this more and more, but I'm curious as to how the rest of the panel handles that, and whether we should be.
I'm just going to cut in 1 second. I put everyone in a high-dose statin. I check no tests, and it's generic. So I think this is a myth that was from the older agents for cholesterol, but we incredibly see infrequent results. And so anybody in the room who's scared of statins, they shouldn't be. So everybody in my clinic gets atorva 80 or rosuvastatin 40, period. So the other ones, I think they're harder. And then this, Brian, you're like such a wonderful clinician. I think these are myths that happened when we were earlier on with our other statin agents. But for anybody who's scared of statins, that's about 10 years old now. You guys can go straight to 80. I promise you. You can call me if you have any problems with that. I'll take care of the it's on the record now.
Can we put Eric's phone number?
Yeah, it's on the thing.
So, Brian.
Hold on. I agree with you. And I also have never had an internist get mad that I'm doing the best thing for their patient. But let me bump it up to Repatha. A lot of our patients ought to be on Repatha.
Well, so that's and that one's a much harder one even for me. So I totally agree with that. I mean, I'm satisfied to seeing the PAD patient on a high potency statin. Repatha, for people who don't know, is a PCSK9 inhibitor. It's an injectable for lipid lowering, which actually has great event reduction for major adverse liver events in some of the trials, primarily in the cardiovascular space. So that one's the harder, and we've tried to figure out how to do this through specialty clinics and lipid clinics and whatnot. But at least, I think that people always should feel comfortable. Aspirin, ACE inhibitor, Xarelto, and statins are very easy, safe, and quick in clinic for the most part, if they can be covered, yeah.
All right, I'll give them your number if they have to. Go ahead. Sorry, Raj, I cut you off.
Just zoom me. Yeah.
I was going to say, you can send all the renewals to Eric also.
and the pre-auth for the Repatha.
That's right. Let's keep it going.
Interacting with the primary care, which Brian and all of us were scared, referrals and so forth. I tell you, I never had a single phone call from a primary care complaining that I did something. They're so busy. And I do tell the patients, we have a little educational pamphlet in Spanish and in English, this is your cocktail for PAD. There's a new medication for you if you haven't, or somebody told you you should, but you're not. Most of them who have hypercholesterolemia are already on medications, but the ones that are not are the plaque patients anatomically without LDLs being too high. And those are the ones that you end up putting them on statins, and you tell them. And then you tell them to check with the primary care, tell them the vascular surgeon put you on, and they have any issues, please feel free to call them. They never do. And we follow them longitudinally, and they tend to be objective, yeah.
Eric, should we be using DAPT at all?
Yeah, we talk about this a lot. I mean, I think, again, my bias as an interventional cardiologist is when a stent goes in, I like to be on DAPT. And so that's been a hard one for me to give up. And so typically we'll do, depending again on the outflow, how much stent we've put down and how the procedure went, we'll do 1 to 3 months of dual antiplatelet therapy. And then it's a discussion of starting Xarelto right up front or switching out the Plavix at 1 or 3 months to Xarelto. Typically that has been more frequent what we've done than putting on triple therapy. But outside of a stent, if it's a DCB, PTA, anything else, I'll go straight to, I don't think Plavix does anything for a balloon angioplasty. Grafting, I'll defer to my colleagues here, but that's been our approach from a percutaneous treatment.
How about you, Elizabeth? Or let's say you did a bypass below the knee, or above the knee. Maybe take your pick, or tell me what's your algorithm at this point.
No, I think for bypasses it's aspirin, high dose statin. I put everyone on 80 milligrams of Lipitor, 40 of Crestor, without a doubt. I don't think I've never had a primary care doctor be upset about it. I've actually been really interested. I'd be interested to see what your thoughts are. A lot of younger patients who have pretty recalcitrant lipids and pretty aggressive restenosis, and they're young. I've been working with one of our lipid physicians in looking at a lot of lipoprotein A. And I don't know kind of what your thoughts are about that. I've been doing a lot more Repatha referrals as well.
Yeah, I think, and that's a huge emerging area in lipid therapy right now, because we've never spent a lot of time checking it because we didn't have a lot of therapies that reduce it. So statins do to some degree, but really don't target as much as newer agents like PCSK9 inhibitors. So I think if you have that available, it's nice to know. And then again, even for me, I work with our lipid team because I don't have the capabilities myself. The other agent also is for people to know, there's a really easy one is Zetia. Ezetimibe is a generic now. It is no contraindications, no adverse events really. It's a completely easy one. And it's been shown in some sub-analyses of larger cardiovascular trials to reduce limb events if you're thinking about bridges to a Repatha or other type of agent. But great comment, Liz.
Looks like we have a Vishal?
Yeah, so just a question. I know we have guidelines or some guidance on management of DVT, anticoagulation, and duration. In regards to acute limb ischemia, once you have technically treated the patient by your CDT, pharmacodynamic lysis, whatever it might be, patient is ready to go home. What's your medical management? Aspirin, Plavix, DAPT, with rivaroxaban, 2.5 BID, full dose for a month, half dose. Like, how do you pick and choose your medications or your management?
Sounds like me calling you, Eric. That's what I ask Eric all the time.
This is the hardest one. I mean, I think again, I'm going back to Liz's talk. The most important thing first is why did this happen? I mean, it's very rare where an acute limb patient leaves our hospital who's gotten debulked or treated and not on a full dose anticoagulant for some period of time. The harder question is that 90 days? Is that 180 days? Is that a year? Or is that forever? Right. And so, I always encourage, we do all our consults also for any of these, and we work with our vascular surgery team on that. And so our protocol is always, the usual echocardiogram with bubble study, a monitor to go home on, trying to figure out why if we don't have a clear reason. If we never find a reason, that's a shared decision-making conversation with the patient, and we'll go from full-dose anticoagulant to 2.5 milligrams twice a day. If it's something we uncover, like an atrial fibrillation or another lifelong indication, we keep them. I would say one thing, though, we do not, I can't remember the last time I prescribed warfarin for anything outside of very specific cardiac indications like a mechanical valve, failure therapy, antiphospholipid syndrome. Outside of that, everybody's on direct oral anticoagulant at this point.
Great discussion, panel. Thank you. Matt, you have a question. I'm sorry. Quick question.
I just wanted to congratulate Eric for completely derailing the endovascular and surgical management of acute limb ischemia. PK, I think you've got your next session next year for medical management. And this is really an exciting area. We've looked at our population of patients in our metro in Kansas City of about 16,000 patients. And there's a 35% risk reduction for all of our patients with PAD, just simply getting them on an aspirin, a statin, or an angiotensin inhibitor and get them to quit smoking. There's a ton of value, and we really need to do a better job in doing this for our patient. In our population, only about 28% of our patients are on that best practice, which is not controversial. And I've talked to primary care groups who are more than happy for us to take the lead on this, because they tell me that they've got about 28 hours of work to do every day to respond to all their in-basket messages and everything else. And so we as specialists who are really committed to this population need to take ownership of the issue.
Great. Thank you, panel. Great discussion. A lot of stuff we have to learn still.